It is my pleasure to introduce Ronelle, Caseky, and Nicole McMannis. They'll be speaking on the ins and outs of voiding dysfunction. Ronelle has over 25 years of pediatric nursing experience in general surgery, transplant, and urology, spending the last 2 years in the urology, caring for children with a variety of different diagnoses. Nicole McMannis has been practicing in pediatric urology for 14 years in a combined setting of inpatient and outpatient roles. Welcome.
Thank you for allowing Nicole and I to join you about talking about voiding dysfunction. This is something that we speak about every day in our clinic visits with our patients and their families. Nicole and I are part of a group of 8 nurse practitioners, and we see urology patients in the main campus at Seattle Children's. We also have outlying clinics in Federal Way, Bellevue, the North Clinic up in Everett, and then we have a nurse practitioner in the Tri-Cities too. So we're seeing kids all over the Sound, and it allows people access when it's hard to get into Seattle. So our objectives today is to briefly review normal voiding and define lower urinary tract dysfunction, summarize common management of voiding dysfunction, and then identify red flags of pathologic voiding. We have no disclosures, and these are some comments we hear daily in clinic. We typically see 4 to 6 patients in one clinic visit that is related to voiding dysfunction. A lot of times parents come to us with concerns that their children have a pathologic or an organic problem, why their children have these problems, and it can be very frustrating for parents. It can sometimes be frustrating for the patients too, but that is what we need to get to the bottom of, is that is this truly a pathologic problem, or is it something that we can help walk them through and figure out solutions to get them through it. So normal voiding occurs from a complex nervous system at various sites in the spinal cord, brainstem, midbrain, and higher cortical centers. I will often just quick pull this picture up on the right to show families that when you go pee, it's very complicated, and there's a lot happening in our bodies. Not for them to figure this out or learn it, because it is complicated. But when the bladder fills, signals go up to the brain, and that's interpreted in the pontine McDrishin Center, also known as voiding or peeing. And then a signal comes back down, and the nerves go through the sacral or spinal cord, and then attach to the bladder and allow the bladder to squeeze. Now, the one thing to note is that the higher cerebral centers can modify the function of the pontine McDrishin Center, and that means that children can override the system and hold, and that's where we run into a lot of problems. And then on the left, normal bladder filling, with normal bladder filling, the detrusor muscle relaxes, and it should fill under low pressure. So if we were to put a catheter in the bladder and measure, it'd be less than 20 centimeters of water. And during this filling phase, the pelvic floor and the sphincter contract so that there would not be leaking. As the bladder fills to about half full, the urination is voluntarily inhibited until the appropriate time. When it fills, and you can see at the bottom, the signal's happening, and it is telling the child it's time to go use the bathroom. They sit, and the detrusor muscle contracts. The pelvic floor and the sphincter relax and open, and normal voiding occurs and then repeats. Typically, by about 6 months of age, bladder capacity increases and the frequency of voiding decreases. So you'll see more time between wet diapers. Previous to that, when the infants are voiding, it's more of a reflex, and the bladder is very small. As an infant, they have a bladder capacity of about 30 mils. By 1 to 2 years of age, conscious sensation develops. And then by 2 to 3, the ability to initiate and inhibit voiding from the cerebral cortex develops. So this is around potty training time. This is also the time when kids become very good at holding, and also at that age, the 2 to 3 years, they may have opinions about using the bathroom as well. School-age children will normally void 4 to 9 times a day. And then 85 to 95% of children are continent by the age of 10. So very common to still see accidents throughout this time, leading up to age 10. And then normal bladder capacity, we use this on a daily basis because we want to know what a typical bladder can hold for that age. That's helpful when we're in clinic and actually can have a child void if they're full, which is not always true because they've usually peed in the waiting room or in the bathroom before they come in. But for example, so a 5-year-old, we would add 2 to that, which would be 7, and then multiply by 30. So 210 mils would be the capacity for a 5-year-old. So voiding dysfunction is an umbrella term we use to describe abnormalities of the bladder in the filling and storage phase and then the emptying phase. These are without pathologic or organic problems. So one of the more common ones we see is the overactive bladder. And this is involuntary detrusor contractions during the filling phase, and it's referred to as detrusor overactivity. So these children will have urgency. They'll all of a sudden hold and have to run to the bathroom. The older children may be able to hold their sphincter and pelvic floor tight during these contractions, but the younger children most often aren't and will have a lot of accidents during this time. The bladder, by having an overactive bladder and holding, this actually makes the problem worse because the detrusor muscle, as you can see in the right picture, hypertrophy. So this bladder's been going to the gym, it's building its biceps, it's strong, and it can override the sphincter at times. It's also thought that the bladder can be more sensitive to irritants or become hyperactive with anxiety or if the child is stressed. This can also be seen with constipation where the rectum is pushing on the bladder, causing it to be irritated. Postponement is probably one of the more common ones we see where the bladder is full, but children are busy doing other things and the last thing they want to do is go use the bathroom. So they'll usually have an accident before they reach the bathroom. So like if they're before they go out to recess and they don't want to miss recess, or video games is a common one, or watching a show or playing with friends. They are ignoring the signal of a full bladder and they wait. And then there's benign urinary frequency. These kids go frequently 5 to 15 times every 5 to 15 minutes, several times in an hour. It tends to not happen at night or when they're distracted. And when we do tests on these kids, urine or ultrasounds, anything like that, everything is negative, and it's thought to be maybe anxiety or stress, or it could even be from irritants like being dehydrated or things they're eating or drinking. When we get an ultrasound, you can actually see this bladder hypertrophy. So the pictures down below are bladder ultrasounds. The arrows show on the left very small bladder detrusor muscle. It also is, the bladder's a bit fuller there, so you're not going to see as thick of the detrusor muscle. But on the right, you can see that the thick layer goes all the way around the bladder, and that is a bladder that has been working hard. So then you have the lazy bladder. I feel like we find these in the teenagers where they postpone and they hold it all day long. They may only go once when they get up and then in the evening just a few times a day. This over time stretches the bladder out. The detrusor muscle becomes stretched out and it loses its contractility and it can't empty all the way. So these kids could hold 600-700 mils in their bladder. They void, and then when you get a bladder scan, they may have a couple hundred left. So their leaking or accidents may happen after a void just because they never emptied. Dysfunctional voiding falls under the term of voiding dysfunction, but this is where the bladder contracts and kids hold their sphincter, and they become so good at it that it's hard for their muscle to overcome the sphincter. And so you'll see some hesitancy where it takes time for that sphincter to open. or they have to sometimes even use their abdominal muscles to overcome the sphincter in the pelvic floor. Vesicovaginal voiding is commonly seen in obese children or girls with bigger thighs, and when they sit on the toilet, their thighs touch, and then they have retrograde flow of urine into the vagina. And then when they stand up, they may have some leaking out, or it just kind of stays trapped there. And then if they have some coughing or laughing, they'll have urine flow into their underwear. So kids come in with history of bladder infections, but then when you look at their cultures, they're all negative. So you have to kind of determine, are these symptoms due to other problems, or is it truly bacteria? Because they can look very similar. So some of the symptoms of irritation and bladder infection are painful voiding, frequency, urgency, very foul smelling urine, cloudy urine, and accidents. And this risk is increased because of incomplete emptying. So when that urine just sits there, it can become very foul smelling, especially if they're not drinking enough water and it's very concentrated from holding, and then constipation. So what is a true UTI? We hear that kids are placed on antibiotics, and then you look at the culture and you're like, not really truly proven UTI. But what we look for in urology is that there is a single growth of an organism, and it's greater than 100,000 count. We also see that there's white cells in the UA and greater than 20. So if you get some bacteria, but there's no white cells, or like 0 to 4, their body's not mounting a response to that bacteria. So they're colonized most likely. Other findings that we can find on urine analysis is a high specific gravity. So we find a lot that kids are not drinking enough water, and crystals can be present as well when they are dehydrated. Some institutions will use a voiding survey in children just to get a sense of how dysfunctional their voiding is. We don't use a formal one in our clinic, but we ask a lot of questions that are similar to things you'll see in surveys. And then when they come to see us, our history is very, very important, and we really need to listen to what the concerns are of the parents or caregivers along with the children. We can really gather a lot of what's happening when the parent seems more disturbed and concerned, and the child may not care at all. Or you get some of the teenagers who they're really embarrassed and they don't want to talk about it. They don't even want to be in the visit, and it takes a little bit of time for them to warm up. The medical history is important to know. Do they have any history of things that would make me think there's interruption to the nervous system? Do they have a history of like a brain tumor, or did they get radiation or chemotherapy that would interfere with those signals? Or do they have a sacral anomaly, an anorectal malformation? Most often, a majority of our patients have no past medical history. They're healthy children. And also, if they have a psych history of like ADD, ADHD, or ODD, those can be very important to know, as that really influences voiding dysfunction as well. So milestones, if they're not meeting other developmental milestones, we usually will see a delay in toileting as well. So social history, if there are stressors like moves, if a family, if there's a divorce, that could be a sense of why this is happening. And then also, are accidents occurring? Where do they occur? Is it both at home or school? Because typically, if it's a problem, it should be going across all modes of that child's life. And so then you would have to question, well, what's happening at school? Is it structured, or do they get home and there is not structure? So those are questions that are important to ask. Again, kind of toilet training, was it easy, difficult? That goes up to the milestones as well. Frequency of voiding. So are they going every 5 to 15 minutes, or is it twice a day? That will give us a sense of what type of voiding dysfunction they have. Is the urinary stream weak? Are they having to push? Do they have hesitancy? that can give us a sense too of the sphincter and the pelvic floor. Are they withholding? And do they have potty holding type behaviors where they're sitting on their perineum or using their hands to hold? And then the frequency of incontinence. Is this just like in the morning? Is it multiple times during the day? Are they coming home with a bag full of wet clothes? And is it just dribbling, or is it full bladder releases? Are they aware that they're having the accidents? We also want to know if they do have a history of UTIs, painful peeing or blood, because those could be a sign of withholding, inability to empty. You have bacteria sitting there growing. And then how much are they drinking? We find that a lot of kids don't drink enough fluid. And then many times when they're at school, they don't want to drink because they don't want to use the bathroom. Or they just save it till the afternoon. They just aren't interested. And then also we have to think about abuse, because we do see it occasionally, and we need to ask if there's concerns with the family members. Very, very important is poop, because it will influence the bladder, and we will not be able to move along and make things better as long as there's constipation. So the question to ask is, do they have daily bowel movements? What do they look like? Do they have to push or strain?
I don't know.
A lot of times they'll come to us with a referral that says they don't have constipation, and then you show them the Bristol stool chart and they'll point to like 1 through 3, and they are having some difficulties. I don't always get an x-ray to show this, but sometimes I will if I suspect this is a problem and the parents do not. The physical exam, it is interesting when families think that the child may not have other problems, and then the child's running around the room, turning off your computer, turning the lights on and off, getting into things, and truly is exhibiting some ADD or ADHD. That can be one sign. Do they engage? So are these teenage kids disturbed that they're having accidents? And they may feel depressed. You can just kind of get a sense of what their affect is. Abdominal exam, don't always find things on an abdominal exam, although it is important to check. On the GU exam, sometimes you can see labial adhesions, which would be a sign of urine trapping. Those children would most likely have dribbling afterwards. Does the urine smell bad? Can you see it in their underwear? Sometimes you'll see stool marks in their underwear too. That may just be from wiping as well, but sometimes they do have some stool leakage. For males, seeing if they're circumcised or not, do they have phimosis, and what does their meatus look like, because some of them can have meatal stenosis following circumcision. For the sacrum, we want to make sure there's no pits, dimples, tufts of hair, anything that would tell us that there's something underlying in the spine and the nervous system. And then some kids can have very flat buttocks. That could be a sign of sacral regression. And do they have a normal anatomic position of the anus? It's very unusual to find lower extremity abnormalities, but it is important to see, do they have weakness? Are they coordinated? Any high arch feet or toe curl could be a sign of like a tethered cord. And then these are just some pictures to point out that we will find on exams. So on the left is phimosis. You can see the white scar. Some boys will come in with kind of urgency, dysuria. They'll have pain at the tip of their penis. You do all of the formal interview during the history, and then you see this and you're like, oh, this might be the problem. And it needs to clearly be fixed. But it may or may not resolve their urinary symptoms, but it is something we would want to take care of first. On the right upper are labial adhesions. We typically do not surgically correct this. You can use creams like estrogen and steroid creams, but typically these resolve when girls enter puberty with estrogen production. But if it is clearly causing a problem, we can try the creams. And then meatal stenosis on the lower right, where the meatus is very tiny, and we would treat that with a meatotomy. And diagnostics. So We will sometimes get a urine analysis in culture, but a lot of times it's hard to get a clean catch in clinic because we are doing the Euroflow, which is a test with EMG, and that gives us an idea of the how the flow of the urine is and how long does it take. It can give us an idea of what type of voiding dysfunction they have. It's very rare for us to get a renal ultrasound, an X-ray, a VCUG, urodynamics, and spine MRI on the first few visits. This would be where there's red flags and where we need more information. But typically we wouldn't get those as our initial visits. So Euroflow, this is something we try to get in clinic if we can. It really is helpful if the children come with a full bladder, at least half capacity. Otherwise, we really can't read it. And so these are some curves that we may see. The child voids into the toilet like normally through the funnel, and it's captured, the urine's captured in that container at the bottom, as you can see on the floor, with a sensor that reads out the flow. So the upper right is a normal parabolic curve. That is what we should see as a normal void. And then you can see on the middle left, the tower curve could be a sign of an overactive bladder. So you get a big, strong contraction, and that makes your max flow rate go high. And then you have the interrupted curve, which is flat. That could be a sign of some form of obstruction, like a stricture or a very tight sphincter. And then the light, or the lower one, the staccato on the lower left, we see that frequently, and that's where the child is having difficulty relaxing the pelvic floor or the sphincter. And so you'll kind of see where it opens and closes, and you get that staccato type look. And then the lower right is interrupted, and that can be from the lazy bladder, where they'll use their abdominal muscles to contract, to push the bladder, aid emptying, and then they'll pause and then have another contraction. These are some examples of patients in our clinic, and the the top picture is a 17-year-old boy who had hesitancy and just complained of a weak stream for several months. You can see it took him, actually, I think it even kept going off the chart, but over a minute and a half to void, and his flow is very flattened. His flow rate's very low, and he indeed had a urethral stricture and required surgical repair of that. The left lower is a normal curve. So you have the parabolic curve, and then the EMG activities below. We put stickers on the perineum, and you should see that the muscles relax during a void. So it's less busy during that parabolic curve. And versus on the right, you can see that there's some staccato and interruptions. And this child has a lot of EMG activity. They're holding their sphincter. They're not relaxing their pelvic floor. And the upper right, that's a VCUG. And if we were to get that, you may actually see a spinning top urethra. So that's where at the very bottom, it's narrowed or it's tight. And then you'll see backflow of urine, and you see that dilated urethra. So that's something you may actually see if we were to do that study along with our Euroflow. So bladder ultrasounds, like I said, we don't typically get these right away, but if we do, these are some things that we may see that would be red flags or concerns. And so the left kidney is a normal kidney, the picture on the left, and you can see no black. And so on an ultrasound, when you see fluid, or in this case urine, it would be black, like you see on the right. So the right kidney has a lot of backflow. It's pushing out. You can't really even see the meat of the kidney because of the pressure of the urine pushing back into the kidney. So that's a hydronephrosis. Things we may see are like the thickened bladder wall, like we saw earlier, debris in the bladder, potentially a bladder mass, which would be very rare, but it does happen. And then you can see here the debris in the bladder. That would be a child who's not emptying. They have some bacteria and they just aren't able to empty all the way. Maybe the example of like a lazy bladder. You should not see a ureter on ultrasound. So you can see in that middle picture, there is black or backflow of urine, and it is dilated. Usually when you see something like that, you would be concerned for an obstruction downstream. And then on the right, you can see a thickened bladder. And then the blue arrow is pointing to kind of outpooches in the bladder. That's trabeculated. And that's where we would be concerned about a tight bladder that's filling under high pressure and it doesn't stretch out and fill under low pressure.
And now that Ronelle has talked about the different types of voiding dysfunction, we'll go into the management of voiding dysfunction. So for our patients, the goal is to normalize the voiding patterns and improve their quality of life. This does significantly impact a lot of these families and the children as well. And so that is the main goal in treating these patients. The first line is standard urotherapy, and about 50% of the patients will see resolution with standard urotherapy alone. So what is urotherapy? So this is kind of an easy way to think about it. We say the rule of twos. So time voiding schedule, pee every 2 hours, sit on the toilet. So 2 minutes on the toilet with a stool under their feet, a bowel movement, number 2 daily, and then pee 2 times. So we'll go into each of these in a little bit more detail, but this is an easy way for families to kind of remember it and for the kids to remember it. So time voiding is probably one of the most important things that you can implement. And I think this is an area where school nurses, nurse practitioners, and primary care offices can really have a big impact for these families, especially, even if you want to send them to us, you can always have them start these things before they come to see us. And these are things that don't require, medications or diagnostic imaging, but you can implement for anybody. So time voiding, we want them to pee every 2 to 3 hours. And it's important to explain to families that this is even in adulthood, that this is, something that we want all people to be doing. Some people are like, well, my kid pees all the time. And I'll ask how often. And they're like, well, every couple hours. They're like, but my other kid can go, 6 hours without peeing. And I'm like, well, we actually don't want your other kid to go 6 hours without peeing. So kind of talking about what the normal is and educating them on that is important. We want them to do the time voiding to prevent the overflow incontinence, to prevent that voiding postponement. This will decrease their risk of UTIs as well. A lot of times for kids, if you postpone voiding, what happens is that they get another signal they need to pee, but that one comes so fast, they have no time to get to the bathroom. So we really need them to go on a schedule because they ignore that signal a lot because they're busy playing. Going to the bathroom is the last thing that they want to do. And this is at home and at school. So kids cannot implement this independently. They need some structure and reminders. So some things you can use are voiding watches. So there's a lot on the market, different options out there. I always just tell families, get ones that vibrate so they don't interrupt the class. Other kids don't need to know what they're for. They can look just like a normal watch. The nice thing with true voiding watches, though, is that the family can set it ahead of time and the kid doesn't need to know how to set it. It goes off to whatever schedule the parents have set it to. So you don't have to have them, turn it on or turn it off. It just will go off. They go to the bathroom, go back to class. For the parents to work with the school nurses and the teachers with this program, because this needs to happen in all the environments. Consistency is going to be really important. On the note for schools, another thing that we'll see is that some of the barriers that kids complain of is access to the bathroom, but as well as them not being clean or them not having doors on the bathrooms at school. So some of the kids will not go for those reasons. When children have mentioned those concerns with those barriers at using the bathroom at school, I will write in addition to the schedule on the note for school to let them use a bathroom that has more privacy, maybe an adult bathroom or the nurse bathroom, to do everything we can to help them be successful. When using public restrooms, the thing that comes up often is the automatic flush toilets. The kids hate those. So you can often use sticky notes, have the parents go in first, put a sticky note over the sensor, and then have the kid go in and use the restroom to help them feel more comfortable with using the public restrooms. Next is positioning. So we want them to sit with their feet flat and supported. And this is even for boys. So you'll have the boys say, well, I don't want to sit down to pee. So I usually encourage them to try this first at home and then implement it at school if they're seeing improvement. Do it at, when they can, as much as they can. The other important part is having them sit there for 2 minutes to fully empty. Kids are really wanting to go back and play. So they'll rush in, they'll pee really fast, and then they'll go back out. And so they don't give themselves enough time to fully empty their bladder. If girls are having trouble with vaginal voiding in particular, and they're having trouble keeping their legs wide apart, sometimes you can actually flip them around on the toilet and face backward, and that will automatically force their legs apart. The other thing is they often need to take off their skinny jeans or their little leggings that are really tight to be able to separate their legs. So having them take one leg out. I know that this is not an easy thing to do at school. So, trying to do it as much as they can is important. Constipation. So like Ronelle talked about, this is really important. We say number 2 is number 1, really, because we can't get anywhere with the bladder symptoms if we're not treating the underlying cause of constipation. So what happens is that the poop will push on the bladder and it causes pressure on the bladder, and they share the common nerve innervation. So full rectum confuses the bladder a lot. And so the kids can't sense when their bladder is full if they have a lot of poop pushing. It also impacts their ability to empty completely, and it can increase frequency as well because then they aren't empty and they need to go to the bathroom more often. So we must treat the constipation to see the bladder improve. It can also decrease their risk of UTIs once you treat the constipation, because when they have a higher volume of constipation present, then they have more bacteria around the bladder as well. So our goal is that they have a daily bowel movement that is soft. So number 4 to 6 on the Bristol chart. We do give them a chart to go home with so that they can follow this and track this. I ask that the parents go in every once in a while and look at the poop and see what is currently happening, to make sure that we're making progress and that we all know what's happening. It's amazing when the families come into clinic. A lot of times they have no idea what's truly happening. There'll be a huge disconnect between what the child says is happening and what the parent says is happening. So once we start to talk about these things, it's important that they continue those conversations at home. The chart is really helpful in getting that when you get the history as well, because like Ronelle said, a lot of times they'll say, oh, they poop every day. So, we need to know what it's looking like to know, and education with the families on constipation. There's a myth that if you poop every day, you're not constipated. So knowing that you can poop every day, but still have constipation is really important. I use the analogy of cars on a highway. So you can be sitting in traffic, right? You're bumper to bumper. There are cars exiting that highway, but you're still sitting in bumper to bumper traffic. So it's the same with constipation. You can poop every day, but there's still a big backup of poop in there. So if they're not getting enough out, they've had this chronic history of constipation, pooping every day is often not enough. I explain to the families, we need them to be expert poopers. So, what is fine for your other kid that doesn't have bladder problems might not be enough for your child that's having accidents. So constipation management. We are not experts in constipation because we're working in urology, but often it goes hand in hand. So we will start with some of the constipation management. Increasing water is one of the biggest things because a lot of children are not drinking enough water. This is the other thing that we'll try to include in our letter for school, to allow them to have a water bottle at school as well. They spend a lot of their time at school during the day. So if they're not drinking at school, by the time they get home, it's really hard for them to get in enough water. For the kids, we like to use this picture, and we do send them home with this chart as well, just so they can kind of see the color of what we want their pee to look like. If it's dark yellow, they're not drinking enough. And that's an easy way for them to keep an eye on things. For parents, they often want a number, and that will vary on age and size, and then also based on their activity level, how hot it is outside. But a good target is half their body weight in ounces. And then increasing fiber, you can use fiber gummies if needed. We have list of high fiber foods that we can give them. And then doing a sit program where they sit on the toilet after meals for about 10 to 15 minutes to promote bowel movements. A lot of kids just don't want to take the time out of their day to sit and go to the bathroom. So we really need to encourage that. They can look at a book on the toilet, different things like that to encourage that. And then the positioning, again, is important to help with relaxation. Often kids do need medications in addition to just these above habits. The first line that we typically use is Miralax. Some families are not comfortable with that, so magnesium supplements are another option. You want to make sure that they are healthy and they don't have any other medical conditions that this would be contraindicated. Miralax will do daily dosing. Some kids do need a bowel clean out with the higher doses 3 times a day. There's a chart on Child from GI. And then exercise, moving their body, is also important to help with bowel movements. If the kids are refractory to these above habits and these things that we've implemented, then we refer on to GI, or the primary care doctor should, because we're not experts. We're not going to put them on laxatives like Senna, like stimulants, I should say. And those need to be managed regularly. So we'll refer on after this point. It's important with constipation management to set realistic expectations for the families. They need to know that they can't just take the Miralax for 2 weeks, that they often have to be on it for 6 months to a year, and it takes time. So we like to say an empty bladder is a happy bladder, and an empty rectum is an even happier bladder. So other things with urotherapy, double voiding. So we tell them, sit down, pee, take your time, get up, walk around for a minute, sit back down, and pee again. And this is really important in those kids that are not emptying completely. So this can help them to recognize that there's still more pee in there when they sit back down the second time. I usually, again, have them try this at home first. If it's not working, they're not seeing a change, they don't have to do it at school necessarily. But if they are, often taking that extra time is worth it, because if they're dry, that's a big reward. So, doing this, it does take extra time, and I recognize that, but it can be worth it. Increasing water, we already talked about that. And then avoiding bladder irritants. There are certain foods and drinks that can irritate the bladder. Carbonation and caffeine are two of the bigger ones, and I recognize kids don't have that often. Artificial sweeteners and sugar are another thing, so juices, those can irritate the bladder as well. So this may contribute to kids that have bladder pain or dysuria, urinary frequency, kind of just that bladder irritation. So avoiding those and seeing if it improves. And then avoiding diarrhea. This is an example of the one that we have in clinic. These are challenging because they can be very useful when they're returned, but getting them returned can be challenging. I think that it's really helpful because we ask them to keep track of how often the kid is peeing, how much they're drinking, if they're having any accidents, the frequency of the accidents, what do they look like, large, small, those sorts of things. And I think more than anything, this can really highlight for the family what is actually happening. Sometimes when they come into us and we start asking these questions, they don't have any idea really what's happening. So this really kind of calls that to light. And then it gives us more information too. This can help us gather a kid's bladder capacity, their actual bladder capacity versus what we estimate on the algorithm. Because this shows us at what point do they normally feel like they have to pee, and because they'll collect the volume, because we'll give them a hat to go home with. And it's 2 to 3 days of information, but they do not need to be consecutive days for those. So Ronelle kind of touched on this earlier, but in addition to urotherapy, it's really important that we treat any underlying conditions. So there's a big component of psychiatric and behavioral problems with urinary symptoms. And so we are not experts in this area. And so we really need to make sure that these concerns are being addressed by others in order for us to help them address the urinary concerns. About 35% of kids with urinary accidents have ADHD. It's a huge number. So treating that can often help with the urinary symptoms, because what happens is they become so hyper-focused on something and then they can't take the time to go to the restroom. So once I've had kids that I saw them the first visit, and if I see the kid running around their room, I'll kind of gently ask the family, are there any concerns with them being able to focus at school or pay attention? Do you see anything in other areas of their life? And if they say yes, then I'll often just explain that there's a strong correlation between the two. And if we can get the ADHD managed, we may see a significant improvement in the urinary symptoms. And so I have had kids that have been in the office and then they come back and they're on medication and things are drastically better, if not completely improved. So that is a really, really important factor. PTSD, this is definitely for kids that have a history of abuse. We can see a lot of urinary concerns related to that. So discussing that, making sure that they're getting counseling for those concerns. Oppositional defiant disorder, the struggle with this is that it's difficult to get them to adhere to the program if the parents are struggling with the kids listening or working together on that program. So we need to make sure that this is working together. A lot of times psychology or psychiatrists, they can help if the parents are like, this is the program we need to be working on, these are the things that we need to be doing, but we need that piece to be there as well. And then anxiety often will contribute to urinary frequency. So we do typically like for the primary care providers to be the ones to place these referrals. I know that it can be hard to get kids in for mental health therapy these days, but a lot of times the families are not local to where we are, and we don't know all the resources in their area. So it can be really helpful for the primary care providers to make these referrals. So second and third line therapies, some of these are not as common. Pelvic floor physical therapy is probably what we use the most. And then we'll go into each of these in a little bit more detail. So pelvic floor physical therapy can be used for patients that have the detrusor sphincter dyssynergy and dysfunctional voiding. So if you see the kids on the Euroflow that have the intermittent or staccato streams, it can be helpful to initiate pelvic floor physical therapy. For those kids, we might even do that after the first visit. But in other kids, we might try the other things first and then go to physical therapy if we're not seeing improvement. Other uses could be incomplete emptying, kids that have dysuria or bladder pain, and urinary urgency and frequency. So with pelvic floor physical therapy in kids, this is all external. There's no internal work. It helps the patient identify the muscles that they use with voiding. Like Ronelle talked about, it's a very complex system and there's nerves involved, but there's also a lot of different muscles. And so the pelvic floor physical therapist will often do an evaluation of their muscles to see if there's any muscles that are really tight or ones that need to be strengthened. Because if things aren't working in coordination appropriately, it can be hard for the kids to void. And then with kids, a lot of the kids that we send need to learn to relax. Their pelvic floor is too tight. And so it's not Kegels that we're talking about. There's a small subset of patients that do need Kegels, but for the majority of the kids that we're sending, they really need to learn the relaxation. And so in order for physical therapy to be beneficial, they need to treat the constipation first, because if there's a lot of poop pushing, it's hard to relax. Or if they're holding that poop in the rectum, then they're activating those muscles. And a lot of times with pelvic floor physical therapy, they will utilize biofeedback as well. So it allows the kids to play a game where they can see kind of like a bird on the screen, and they have to get the bird to fly higher. So they tighten their muscles, and then to get the bird to go lower, you relax your muscles. And so it gives them that direct feedback that they're using those muscles appropriately. A lot of stretching and a diaphragmatic breathing, and then core strengthening. All of those are things that the physical therapist will utilize to help them with emptying. And then important factor is the age and attention span of the child. So there's no one size fits all, because you might have a 4-year-old that could totally do this, but then you might have a 7-year-old that just can't pay attention for that long. So taking all that into consideration is important. The other limiting factor for physical therapy is access. So we do have one provider at Children's that does it for urology, but she has a small amount of time. And also a lot of the families don't live in Seattle. So we do have a list that we try to keep up to date as much as possible of physical therapists in the areas, outlying areas. But some of them don't accept the patient's insurance, or there's one pediatric primary physical therapist there, and then they leave and then they don't have someone. So they often have age limits that they'll take. So knowing all that information can be hard. So trying to get them access to it is also a challenge sometimes. Then medications, which I will say we rarely use in these kids, but oxybutynin is one that we may use for the kids that have the overactive bladder, the uninhibited bladder contractions. This relaxes the bladder to increase the capacity and calm those contractions. So, things that are important to make sure before we start them on medication is that they're following the urotherapy first, and that they don't have any constipation, and that they're emptying their bladder completely, because side effects of this medication are constipation. So you're just going to make the problem worse, and urinary retention. So we don't want to put them at risk if they're not emptying to make that worse. Dry mouth, flushing, drowsiness, heat intolerance are other things that you can see with this medication as well. And so I will say that, first line is urotherapy. They come back to clinic usually about 4 months after we see them the first time, and we see how things are going. A lot of the kids are not going to be completely better by that point. We're not going to have solved all of the problems. We just want to see that they're making some progress. In some cases, they aren't. Doesn't mean we're automatically going to go to the second line therapies. It means that we're going to have a conversation with the family and figure out what's going on, because sometimes they really haven't done any of the things that we recommended. So So good history is important to make sure that we're not just jumping to something else when we haven't actually done the other things, because a lot of times, like we said, it does help. The urotherapy is usually the thing that does the most for these kids. And then Flomax, this is for kids that have delayed initiation on the uroflow. So the study will start, and sometimes you'll see a big lag to when the kid actually starts to pee. And the kids will tell you, it takes me a long time to start peeing. And so this promotes relaxation of the smooth muscle in the bladder neck to help them with that initiation of the stream. Side effects, orthostatic hypotension. And so taking this before bed is helpful to minimize that. It's just a once-a-day pill, so that's helpful. You may be familiar with this medication because we use it for stones and also ureteral stent pain sometimes. And then even more rare are plain intermittent catheterization. This would be for the lazy bladder, the underactive bladder. These are kids that have incomplete emptying, and they have consistently large post-void residuals on bladder scan. So this is not a kid that has acute urinary retention, has never been having problems that we need to manage urgently. This is for a kid that we just see that nothing else is helping, but we need to help their bladder work more effectively and empty their bladder. So some of these kids will have recurrent infections because they're not able to empty the urine out. So we will teach them how to do clean intermittent catheterization, and the goal is to protect the kidneys. But like I said, it's rarely used in this population. And then Botox can be used for overactive bladder. It's for kids that are resistant to other treatments or that had too many side effects from the oxybutynin. So they'll do an injection into the sphincter to prevent the uninhibited bladder contractions. Again, a risk would be urinary retention, just like with the oxybutynin. The downside of Botox is that it is an anesthetic, and so they have to go into the operating room to have this done. And just like all other Botox, it has to be repeated. So it does wear off every 6 to 9 months. And then red flags. So these are things that we would want you to escalate either to us, send to us, or things that if we found them on our exam that we would do further workup for. So spinal anomalies, lower extremity weakness, numbness, tingling, tethered cord is what we would be considering there. Neurogenic bladder would be the underlying concern. Recurrent febrile urinary tract infections. If they have high fevers with their infections, that's not just regular UTIs. We want to do more workup, and we want to look for vesicoureteral reflux with a VCUG. Hydronephrosis. The underlying concern with that is VUR, post-urethral valves, neurogenic bladder, and really any of the abnormalities that Ronelle showed earlier. If we find those on ultrasound, a lot of those would warrant further workup, like the trabeculations. If there's hydroureter, anything like that, we would want to do further studies to investigate the underlying cause. And then the flat uroflow, the plateau, is concerning for obstruction. So this could be urethral stricture, meatal stenosis. Those are things that we can treat and have resolution of that symptom. High PVRs, urinary retention, we're concerned about neurogenic bladder or neurogenic bladder. And then persistent urinary leaking. So if kids have continuous dribbling, this is one thing that you really want to try to delineate in your history. Continuous dribbling is a kid that the parents are like, they're always just have a little bit of urine in their underwear. Like they are never dry. So it's not a kid that has an occasional dry day. It's not a kid that can go 5 hours in between accidents. This is a kid that really has this constant dribbling. And that's a concern for an ectopic ureter. And that's the picture that I put there in the lower picture. So it's a kid that has a duplicated system, and they have 2 ureters that are draining the kidney. One of them is going into the bladder usually. The other one may not be entering properly into the bladder. So in girls, it can go into the vagina, or it can go in below the sphincter so that they can't control that urine, and it's just dripping out constantly. And for this, we do surgically correct this, so we want to make sure that we catch that. And then other things, abnormalities on UA. So if they have glucose in their urine, always want to think about diabetes. Protein, we want to think of underlying kidney disease. Both of these are things that are persistent on UA. So one episode of this is not concerning, and we consider trace protein to be a variant of normal. So if this is persistently present, then we want to send them on to the appropriate specialties for evaluation. And I think other key components that are probably one of the most important things for them is education, explaining to them why we're recommending these things. why, to get their buy-in, we need to spend the time with them and explain these things to them. And because a lot of times the families come in, they're like, they think something is really wrong, and saying to go to the bathroom more often and treat constipation, they're like, no, that's not going to work. That's not the problem. So we really need to spend the time and educate them on this. We must treat the comorbidities. We have to treat this other, mental health concerns. We have to treat the constipation in order to see the urinary stuff improve. Sometimes the urinary stuff is actually just the symptom of something else. So it's important to look at all aspects of their life. And then positive reinforcement. We do not want to punish them. None of these kids want to have these accidents. So really positive reinforcement. I find that reward systems don't typically work because the novelty of it usually wears off. But I just think being positive with the families and with the child when we're interacting with them. Consistency is key. This needs to happen, like I said, in all aspects of their life. And I think this is one of the areas where school nurses and school nurse practitioners can really make an impact for these kids, because your help at school is really important, and them being able to carry out these programs and being consistent and compliant with this. I think talking about that for just a minute, I think that I meant to mention earlier, but some schools will restrict access to the bathroom, or they'll give rewards if they don't use all of their bathroom breaks. So I really encourage any school nurses out there to talk with their teachers and educate them on this, because this is a really significant problem for some of these kids. And so I think that just, some of the kids can set up a program with the teacher that they just give a signal and then they run to the restroom. They don't even want to have to say that they have to go to the bathroom in front of the whole class sometimes. So I think working with the kids on this and the teachers is really important to helping them carry this out at school. And then reassurance, letting them know that they're doing the right things. It takes time, it takes effort, and that we're here to help them along the way, but we can't do it all for them. And so I think when I see the kids in clinic, I often, we talk together with the kid. We need to make sure that they are engaged and that they're listening and hearing what we're saying, because the kid is the center of all of this. And so they also have to be involved. It can't just be a conversation with the parents. So I think we are happy to see these kids, but I think there's a lot that the primary care providers and nurses and nurse practitioners can do to work with these families as well.
Does forcing potty training too early, child not physically or psychologically ready, contribute to these issues? And what about elimination communication? Any data to support it?
I will say that there are a lot of children we see in clinic, and you ask about the toilet training history, and they'll be like, well, they trained at 1.5. So there does seem to be some correlation with forcing potty training too early. I usually really am a proponent of waiting till the child is ready and showing interest before we're trying to push that potty training. I think they can learn to hold it when they go through that phase of potty training. And so we really need to work on engaging that schedule from the beginning. So I think, yes, I do think that early potty training can be detrimental and create problems later.
Another question that came through is, do you have recommendations about transitioning from use of a special restroom back to the public restroom? And does it tend to just be developmental in your experience?
That's a great question. That's not something that I have been involved in. I haven't been involved in that process. I think that would be something that would be a conversation with the family and the child on what are the limitations in using the public restroom, and trying to get to the bottom of what are their concerns with using the public restroom, and then kind of taking it step by step and trying to create a program with them. It may be something that it could be helpful to have a counselor working with them on that if they're pretty resistant to it. And this is where I think, the mental health aspect can come into play as well.
Excellent. Let's see, another question that came through. I've had questions from parents asking about normal timing for staying dry during the night, and when they need to intervene versus if the child will eventually outgrow it.
Nocturnal enuresis is hard. We typically, if there's no organic or pathologic problem, we try to reassure them that kids typically will outgrow it with time. We will still see 14, 15, 16-year-olds that are wetting, and 1% of the population still wets as an adult. So, obviously we want to make sure the child is not diabetic, and sometimes we can also perfect their daytime habits. We've had some kids who are severely constipated, and when you resolve that, the nighttime wetting gets better. If they have signs of sleep apnea, like severe snoring, having their tonsils out, that can be helpful. But sometimes there's a strong family history as well, and where the mom or the dad said, well, I wet till I was 12 and then it got better, or you'll start to see that the child is having nights where it's not 7 nights a week, but now it's 5, or you can start to see progress. We typically recommend the moisture sensing alarm because it's training. Back at that picture, the neurologic picture, what happens is the Pontine Micturition Center is sending a signal down for bladder contraction, and the children are deep, deep sleepers, and they're just not waking to that signal. And so what the moisture sensing alarm does is it alarms as soon as it senses moisture, and it's trying to strengthen the brain and the bladder connection. So we encourage that. We don't use a lot of medication to treat it because it's a Band-Aid. You use like desmopressin or DDAVP and for sleepovers, that kind of thing. But if you're not using the medicine, the bedwetting continues. So really the cure is the moisture sensing alarm. That is difficult for some families and it doesn't always work, but it's a lot of reassurance with nocturnal enuresis, and it's difficult.
Wonderful. Do you mind one more question?
Sure.
Okay. One that came through about bladder spasms says, can you explain briefly and how to prevent and help get them out of the restroom? That came from Nancy Johnson.
Is this for kids that are, we'll also see this for the kids that are having this urinary frequency, this feeling that they have to go every 5 to 10 minutes. Not exactly sure if that's what you're speaking to, but I think for some of those kids, more hydration. So I know that sounds silly. A lot of kids that have urinary frequency or that they are having accidents will restrict their fluids, but that can actually irritate the bladder more. And so treating with increasing water to dilute the urine, as well as making sure they're not constipated. In the moment, it can be challenging, but a lot of times we will see this with the kids with benign urinary frequency, and it often resolves spontaneously. But yes, having them, I usually say at home what they can try to do when they're in a safe environment is see what happens if they don't go to the bathroom. If the kid is obviously in a lot of pain, then we want them to go and make sure that they don't have to pee. But if they're not having pain, they just feel like they have to pee and they just went, then waiting and seeing what happens. Some of them are also very anxious that they're going to have an accident, so they just run back in. So, kind of that reassurance that they're not going to have an accident. Sometimes, you could try a warm pack on the lower abdomen if they're at home, if they have access to that. But other than that, there's not a lot you can do in that moment where they feel like they have that sudden urge that they have to pee again. I think it's a lot of working on the other habits to prevent that from happening.